And where is your question? Right, so if you have read and understood, considering its surgical anatomy station, kindly tell me, yes, if you can identify these. What are these arrows? It represents what?
Okay. Which side I should start? In the picture A,
Yes, please.
this arrow is a frontal bone.
No, these black arrows, if you can see, they
Yes, it's
are
black.
pointing at something. Some arrows are thinner, some arrows are darker, and they are
Okay, so
in
these are
variable directions. If you can identify, these are pointing at some structure, veins. What type of veins? So I've given it out.
okay.
Can you
This one
tell
in
me?
the middle.
Yes. What are the diploic veins?
Diploic veins are veins between the dura mater and arachnoid space.
Okay. How are they presented on X-ray? First, you can tell me what kind of image is this and what are the arrows pointing at? I've just kind of told you.
These are the plain X-rays of skull, lateral
Yes.
view, the picture A, and anterior posterior view, the picture B.
Okay. Can you please tell me how many, if you can look at this image and
Yes.
tell me how many dual sinuses are there?
Okay. This picture 1 is the confluence of sinuses. The picture
No.
2.
Okay. In the picture number 2, yes.
2
what
is
that?
straight sinus.
Okay. Yes. 3, please.
3 is I'm not sure. 3. These inferior sagittal sinus.
Okay. 4, please.
4 is sigmoid sinus.
5, please.
5 is inferior petrosal sinus.
6
is superior petrosal sinus.
7, please.
7 is the confluence of sinuses.
8, please.
8 is sphenoparietal sinus.
All right. What about this one? Arrow is pointing at this one, but it is not.
This was the transverse sinus.
It is actually intercavernous.
Intercavernous sinus. Yes.
So most of them you have got them wrong. How would you classify the cavernous sinuses? Is there a way you can classify them?
No, I'm not sure.
All right. How many of them are single and how many of them are paired? Can you tell me that, please?
The superior sagittal sinus, inferior sagittal sinus, and straight sinus. These are single, and the rest of all are the paired.
Can you mention the paired one? There are 6 paired. So can you mention?
The cavernous sinus,
yes.
Cavernous sinus, superior petrosal, inferior petrosal, sigmoid sinus, and transverse sinus posteriorly, and this is sphenoparietal sinus.
Where sigmoid sinus is located, please?
Sigmoid sinus is the 4th one, which continues into as internal jugular vein.
Yes, but where is it located? In the floor of the posterior canine fossa.
It is located at the junction of posterior border of petrous part of temporal bone and the occipital bone.
So between transverse sinus and inferior petrosal sinus.
Yes.
It connects to jugular pulp of internal jugular vein.
Yes, yes.
All right. Can you please tell me, right, which is cavernous sinus?
Venous sinus is this one 7.
Okay. What happens when there is inflammation and it leads to thrombosis of cavernous sinus?
There is an area on the face just lateral to the nose, which is supplied by the facial vein, and there are tributaries which are connected to the cavernous sinus through these ophthalmic veins.
Yes.
And
Then
if there's infection in that area,
yes.
that infection can spread into the cavernous sinus and cause cavernous sinus thrombosis.
Why? Because these veins are valveless.
Valveless veins, yes. These are
So
valveless
can you
veins,
please
so they can be
please tell me what are the signs of thrombosis? How would you confirm that cavernous sinus thrombosis has taken place?
Patients usually present with the swelling of the eye, diplopia, and there's proptosis, and there is signs of compression of abducent nerve, trochlear nerve, oculomotor nerve.
Okay. Can you please tell me what is the relation of where this cavernous sinus is located? So what are the structures which come in relation to it?
Cavernous sinus is located to the lateral side of the body of the sphenoid.
Yes.
And there are the
on either side of sella turshica.
On the side, yes, on the other side. And in its lateral wall,
yes,
lies the trochlear nerve, oculomotor nerve, and ophthalmic nerve. And within the cavernous sinus lie the internal carotid artery and abducent nerve.
Okay. Right. Right. Okay.
Okay.
What more I can ask you? Would you be able to tell me how or it can be a separate question, how the cerebrospinal fluid is formed and transported?
Cerebrospinal fluid is formed through the actinoid membranes, and it is connected to the ventricular system, as well as it passes the outer surface of brain and spinal cord. The ventricular system is two lateral ventricles which are connected to the third ventricle through cerebral aqueduct, and the third ventricle is again connected to the fourth ventricle, and fourth ventricle is connected to the central canal of the spinal cord. The CSF is reabsorbed in the dural venous sinuses. The normal pressure is approximately 15 to 10 to 15, and that's all.
Okay. Can you please tell me what is the mechanism behind I've lost the question, sorry. Because one of the symptoms for cavernous sinus thrombosis is myxedema or the...
Yes.
Yes, so can you please tell me the mechanism behind it?
Because the inferior ophthalmic veins, they drain into the cavernous sinus. When there's thrombosis in the cavernous sinus, the venous blood from the eye cannot drain into the cavernous sinus. That's why there is edema in the peri-orbital tissue leading to myxedema.
And how it leads to diplopia?
Diplopia occurs because of one, pressure in the orbital fossa, as well as there is a compression of the nerves, the trochlear and abducent nerve. That's why there is diplopia.
Can you please tell me the risk factors associated with cavernous sinus thrombosis?
The risk factors are the infection on the face.
50%. Yes. And others?
Others, I'm not sure.
All right. Okay, you told me. Yeah. All right. Good. Thank you. So now, if we can just look at, why it's not. Can you still see the answer?
Yes. Yes,
Okay.
I can see now.
So if you can, we can just confirm and go ahead. This one you
Yes.
said it's superior
Sup-
sagittal sinus,
Yes.
right? And then 2, you said it's a straight sinus,
It's the straight sinus. Yes.
right? And the 3 one, it's great cerebral vein.
Okay.
Yes.
I called it inferior sagittal
Yes.
sinus.
So this is
Yes.
great cerebral vein.
Hmm.
And then
Right.
4th one is sigmoid sinus.
Sigmoid.
So when
Yes.
I asked you where is the sigmoid sinus located, it was in the posterior cranial fossa.
L fossa. Right.
So that's how
Right.
you'll remember it. This is 4th.
Right.
And this is 5th. 5th is inferior petrosal
Inferior
sinus.
petrosal. Right. Yes.
6th is superior
Superior
petrosal sinus.
Right.
And then 7th is
Is cavernous.
cavernous sinus.
Right.
Okay. So that's the location of cavernous
Of
sinus,
the
why
cavernous.
it's susceptible. Then 8th
Right.
one, you had it correct.
Sphenoparietal.
Yes.
Sinus. Right.
Yes, good.
Okay.
Right.
Thank you.
So what are these ones?
These are veins, superior ophthalmic veins, and in the very middle there is a cribriform plate of 8 point.
Yes, yes, that is not labeled. Okay, good.
Yes.
Thank you so much. Thank you.
Thank you. Thank you.
Here is your question.
Okay.
Just wait for the bell, please. Okay, now. So if you have read and understood, considering its surgical pathology station, kindly tell me what are your differential diagnosis for this patient that you'll consider?
Okay. Differentials are basal cell carcinoma, squamous cell carcinoma, malignant melanoma.
Okay, good. Can you tell me, yes, if you can explain or describe this lesion?
Okay. This is a parley papule
Okay,
central ulcer
yes,
with the granulation tissue on the base, and it's a rolled edges.
all right.
That's
How big is the lesion? Because when we have to describe the lesion, we have to tell the lesion in size always.
okay. It's 8 millimeter in size.
Yes, all right, good. Can you tell me why the surrounding skin is red?
It's because of telangiectasia.
Okay, right. Right. Okay. Can you please tell me how you said first one of your differential diagnosis was it could be basal cell carcinoma. Can you please tell me the mechanism? How does it spread?
Actually, this is locally malignant. In case of basal cell carcinoma, it is locally malignant carcinoma.
All right. So there is this 5 steps
Yes,
process,
there is
if you can.
There is 5 steps, including invasion and infiltration.
Yes.
And release of neoplastic cells.
Yes.
And there is a survival in circulation and arrest in capillary beds of
Yes.
different organs.
Yes. How would you confirm your diagnosis? Yes. How would you confirm your diagnosis?
Sorry, may I come back to this question later?
Yes, sure. Which biopsy would you take? Would you be able to tell me? Yes. Okay, if just suppose you've taken the biopsy, report has come back and it is confirmed that this is basal cell carcinoma, what are the treatment options that you can offer to the patient?
Okay, there are some surgical treatment and some non-surgical treatment.
Yes.
In case of surgical, there is curettage and electrodissection,
Yes.
and excision with primary filter, and cryotherapy, and most micrograph surgery. And non-surgical treatment, there include radiotherapy and topical fluorouracil and delta aminolevulinic acid.
Okay, can you tell me what measures would you take for the carcinoma to prevent for the carcinoma to reoccur?
To prevent carcinoma
From reoccurring?
we should follow the sorry.
All right, okay. Right, after the treatment, right, what have you... All right, can you please tell me how would you differentiate or between the basal cell carcinoma and squamous cell carcinoma?
Okay. In case of basal cell carcinoma, we found the lesion within the thick skin and within the deep layer of the skin. And in squamous cell carcinoma, we found the superficial layer, and it occupies the basement membrane in case of basal cell carcinoma, and squamous cells occupies the outer layer, and most commonly peoples are around 40 or more.
How is it different in the occurrence? Can you tell me?
Sorry?
Is there any difference in the risk factor, how it occurs, how it takes place?
Yes.
Is there any difference in location?
Yes, in case of squamous cell carcinoma, there
On what, maybe you can tell me where on the human body, or where on the face, or if there is any particular place where
yes,
it
in case
occurs?
of basal carcinoma face, most commonly affected sites are face and
Okay, can you please tell me what advice would you give to the patient?
advice for patient in case of basal cell carcinoma.
Yes, if a patient has come to you with basal cell carcinoma, you've done the treatment, you've done the management, now you know what type of skin patient has. So what advice would you give to the patient? What measures a patient should take in order to prevent future carcinomas happening?
Okay. So we'll counsel the patient about the disease and management. We like to explain the disease and we encourage patient to avoid
Yes,
sunlight,
yes.
and avoid sunlight, and some
And use what?
treatment,
Yes.
and they can use some topical cream to avoid the sun exposure.
Yes, what type of ointments can be best advised for the patients
Sorry,
to prevent sunburn?
uh, It's a topical fluorouracil.
Yes. Any other?
Topical
Is there any other
photodynamic
criteria? Sorry.
imiquimod.
Okay, if this patient presents to you and patient has non-healing after you have taken the biopsy and patient has taken treatment and now patient's infection is not or the wound is not healing, what would you suspect?
Patient wound is not healing.
Patient, what is the most common post-surgical infection that can occur? Which organism is most common?
Most common organism is Staphylococcus aureus.
Yes. Okay, good. So how should this Staphylococcus aureus infection be treated?
Staphylococcus will be treated with if there is methicillin resistant wound infection, then if there is access, then I would like to incision and drainage of the patient. And in case of outpatient, I'll give oral antibiotics and like oral as clindamycin and amoxicillin plus tetracycline and vancomycin and linezolid. And in case of skin, decolonization with mifepristone nasal or chlorhexidine for body decolonization.
All right. Can you please tell me this after you've removed this ulcer or this carcinoma, and then there is a gap on the face of the patient? How would you advise to cover the gap?
How would I advise?
Yes, patient had this is on the nose, so you remove the tumor, and then there is a gap on the nose, so that doesn't look nice. Patient wants to cover it. What advice would you give, or what measures would you take?
Okay, I would like to do consult with plastic surgeon and then advise him or her for the graft.
Graft, yes. Okay, what is the most common site from where skin grafts can be taken?
In case of right nostril, we can graft from the ear lobule or back of the ear.
Okay. All right. Thank you so much. Started your question and here is your started your timer and here is your question. Right, so if you have read and understood, considering it critical care scenario, kindly tell me, how do you plan to manage this patient?
So after the history, I would proceed with the management of this patient by critical care of surgically by ATLS principles. Sorry. I will start with the airway with cervical spine immobilization. I will look for any foreign bodies, foreign objects inside the mouth, any broken tooth, any soot particles, carbonaceous sputum. And then I will give 15 liters of non-rebreathing bag mask to the patient. And then I will assess the breathing, the respiratory rate, the rhythm, the pattern. And then I will look for any obvious respiratory distress signs like accessory muscle use, any obvious chest injuries like open wounds and the burn injuries, I will assess them as well.
Oh,
And
in
then-
burn patient, you won't find open wounds. There could be like circumferential chest burns, which
Okay.
you would have to maybe take care of. Okay, can you please tell
And
me,
then
yes, please.
I will
Considering,
also assess
yes,
the
please.
airway because as there are soot particles in the nostrils,
Yes,
and then I will anticipate that he got some pulmonary or inhalational injury, and he could potentially lose his airway. So I will consider managing his airway with a prophylactic endotracheal tube. And I will also look for any circumferential chest wounds because that can also hamper in the ventilation of the patient.
ventilation, very good. Okay, can you please tell me, considering the burn which patient has, these are second degree burns, would you be able to calculate how much body surface area has been burned?
So face will be 9, trunk, it doesn't say interior or posterior. So if it's only interior, then it's 9, 18. Left arm will be 4.5, 18 and 22.5, and then both thighs 9 and 9, 18. It doesn't say interior, so should I assume that it's both sides?
Yeah,
Okay, so it will be 9, 18 for the thighs and 18 for the trunk, 36. Face
Alright, good.
9.
Phase 9 as well. Okay, considering that the patient has soot in the nostrils, what does it tell you? Where should you be managing this patient?
So the patient has the potential of losing his airway as he got inhalational injury, which can be up to the
Yeah,
major
but where
bronchi.
would you be managing
So
this patient?
I will manage this patient in the ITU.
Okay, can you give me 3 or 4 reasons? What is the 3 or 4 criteria for managing the patient into burn unit?
So if a patient has facial injury,
Yes,
number 1, if he got full thickness burn injuries
yes,
of any percentage,
yes.
and then in this patient, he got soot in his nostrils, so potentially he might lose his airway. And then he got
Burn as well. So basically qualifies for the burn unit. What
yes.
else? Age of
So
the patient, you have to tell me, and then
yeah,
yes,
age of the patient, if
and
less
genitalia.
than 10 and more than 65, they will go to the burn unit, circumferential burns, burn of the face, extremities, hands, feet, perianal area, and
Okay.
head and neck.
Next question, please. Kindly tell me, how would you take care of the fluid requirement of this patient?
So I will assess the burns first, and then I will apply the Parkland formula, which is 4 mils into percentage of burn into weight of the patient, and I'll give half of this fluid in first 8 hours and the next half in the 16 hours. And I will monitor the resuscitation by urine output, GCS of the patient, heart rate, blood pressure, and all that parameters.
Okay, considering it's a burn, what are the complications that you should watch out for?
So the patient can go into burn shock, hypovolemic shock. The patient can have sepsis. The patient can develop ARDS. The patient can have electrolyte imbalance like hyponatremia, hyperkalemia. The patient can have renal failure or myoglobinuria, rhabdomyolysis due to rhabdomyolysis. The patient can have sepsis, ARDS, and can have arrhythmias because of electrolyte imbalance, hypothermia.
Can you define, please, ARDS, acute
So
respiratory
ARDS,
distress syndrome?
yes, it is the acute diffuse form of inflammatory form of lung injury, which is characterized by hypoxemia, decreased lung compliance, and non-cardiogenic pulmonary edema, which shows as bilateral infiltrates on the chest X-ray. And there is decreased PaO2 and FiO2.
Mismatch, VQ
Yeah.
mismatch. Okay. Can you please tell me, in case of burn, how the extent and depth is calculated?
Sorry.
How the extent and depth is calculated for a burn patient?
So we have we assess them by the appearance. If they are red, they have blisters, they are painful, sensate. Then it's superficial burns. If they are white, leathery, and desensate, then they are full thickness burns.
Okay. Can you please tell me what is Berlin's criteria?
Berlin's criteria is basically to assess the ARDS. It's to assess the ARDS level, like mild, moderate, or severe. If it's basically the arterial pressure of oxygen over fraction of inspired oxygen ratio. In mild, it is more than 200. In moderate, it is 100 to 200, and it's less than 100 in severe cases. And it also helps us in assessing the mortality of the patient.
All right. Can you please tell me the pathophysiology behind ARDS, please?
So there are 3 phases. First, there is the proliferative phase, which lasts for 1 to 2 days, in which there is a widespread capillary endothelial damage mediated by the neutrophils and macrophages via release of proteases and oxygen-free radicals, which leads to interstitial alveolar edema and hyaline membrane formation. This causes also alveolar basement membrane damage, which leads to this fluid seeping into the alveoli and causing VQ mismatch and lung stiffening. And then there is the proliferative phase, which lasts for 1 to 2 days. And there is type 2 pneumocytes proliferation. And there is further worsening of this with proliferation of fibroblasts and all and macrophages. And then there's fibrosis phase, which lasts for 3 to 4 weeks. And in this, there is healing with fibrosis.
Very good. Okay, can you please read this image for me?
So it is X-ray chest AP view.
Yes.
In which there is, I can see there is cardiomegaly, and there is bilateral fluffy shadows in both lung fields. The trachea seems central, and there is no bony defect, and there is no surgical emphysema. And there are some leads which seem to be like ECG leads. And what else?
Yes. What else?
Yeah, there is
What
another.
do you see? The angles. You didn't
Yes,
discuss
so,
the lungs.
yeah. Yes, so the angles, they are cardiophrenic angle on the right side is obliterated. So cardio, yes, and then on both sides the cardio, the angles on the sides.
What about the lungs? How do you?
There are bilateral fluffy shadows in both the lung fields.
Okay.
Which are the which represent pulmonary edema.
Yes, possible pulmonary edema. Yes. Okay, good. Right. Thank you.
Thank you.